this is getting complicated, isn't it? Because in previously untreated patients, the Alliance and ECOG cooperative groups have looked at a comparison of BTK inhibition with rituximab versus immunochemotherapy, different regimens. And in both of those studies recently presented at ASH and now published, there was a benefit in terms of progression-free survival of the BTK inhibitor ibrutinib.
That's right.
And now we have venetoclax and obinutuzumab. Give us some idea of how, let's start with responses. Responses with venetoclax and obinutuzumab will compare to BTK inhibition.
Yeah, so I think in terms of the overall response rate, it's very comparable. You're kind of looking in the 85%, 90% range. Nearly all patients will have some initial benefit. I think that where these two regimens are different is in the rates of complete remission and also getting into minimal residual disease, MRD, undetectability. So for both of those latter two, complete response rate and undetectable MRD, there's a significant advantage for the venetoclax-based regimen. That's really necessary because this is developed as a time-limited regimen, and so you need to get to that deep MRD undetectable response in order to be able to stop therapy and allow for a treatment holiday. In contrast, the model with the BTK inhibitors is to continue drug ongoing, and so in that scenario, it's actually maybe not necessary to get into such a deep response as long as the patients are able to continue taking the drug. I think both are great strategies, and I think it's going to really be up to docs to kind of understand the pros and cons of both and be able to discuss them with their patients.
So can you give us some idea of maybe some follow-up then on the patients who get this time-limited ven and obinutuzumab? What's the median progression-free survival there?
So a median progression-free survival has not been reached yet. And actually, even though this is the first time they're reporting this study, they have a decent amount of follow-up. So the median follow-up is about 26 months. And all of the patients that they're reporting at this meeting actually have completed the full year of therapy, and most of the patients have now gone a year afterwards and are still in remission. So when they look at 24 months, which is 12 months after finishing the therapy, they still have an 88% progression-free survival. So it certainly looks promising that this will be an effective time-limited regimen, but I think it's still an open question as to just how durable the benefit will be. Will it be 2 years, 3 years? We really have no sense for that at this point. And the numbers of high-risk patients in this study were relatively small, only in the range of, I think, 8 to 10% deletion 17p. So it's a little unclear how much these results will apply to that higher risk population.
Now in the cooperative groups, again, coming back to that, the Alliance and ECOG have recently activated studies looking at combinations of BTK inhibition, BCL2 inhibition with venetoclax and obinutuzumab, also looking at whether therapy could be stopped. So you think we might someday move to a triple combination and time-limited therapy?
It's certainly possible. I mean, these are very promising studies combining now 3 drugs with the BTK inhibitor, venetoclax, and obinutuzumab, all in the same regimen. I think it certainly needs to be studied, and I think it's got a good chance of success. In the back of my mind, I do worry a bit if we use our 3 best drugs first. What are we going to treat the patients with when they progress? I mean, we do have PI3 kinase inhibitors. That could be an option. We have CAR T-cell therapy coming along for CLL. That could also be an option. So I think it's a great area to explore. It's not clear to me whether the 3-drug regimen is going to be any better than a 2-drug regimen. Also last week we saw a really promising regimen of ibrutinib plus venetoclax published in the New England Journal of Medicine, which also looks great. So maybe you don't need the antibody at all. We just don't know yet.
And that's what the Alliance study suggested in the upfront setting, that the PFS with both ibrutinib alone and ibrutinib with rituximab were equivalent.
So that was certainly the case. Rituximab does not add any PFS benefit to ibrutinib. I would be careful to extrapolate that to other drugs, even to other CD20 antibodies. So for example, ibrutinib with obinutuzumab may have a benefit over ibrutinib. Unfortunately, the recently published Illuminate study didn't have an ibrutinib-only arm, so that study won't answer that particular question. But I think the ibrutinib-venetoclax combination is going to have very durable responses, and certainly will add to ibrutinib monotherapy.
So can you give the listeners any insight into how you are going to choose between these 2 regimens?
So when I sit down with my next patient who needs frontline CLL treatment, these are sort of the factors that I'll discuss with them. So for ibrutinib, we have longer-term follow-up. So we've seen 7-year data presented on ibrutinib now with excellent PFS. Granted, that 7-year data is only the original 31 patients who were treated in the frontline setting. If we look to phase 3 data, though, we have 4, almost 5-year follow-up now on the RESONATE-2 frontline patients. And again, we see very nice durability. About 2/3 of patients are still on drug and in remission after 4 years. So that certainly looks good. And so those are much longer follow-up numbers than we have so far for ven plus obin. Secondly, another advantage of the ibrutinib data is that we have, as you alluded to, the comparison in the Alliance study and the ECOG study to standard chemoimmunotherapy regimens that we use in younger patients. So FCR for the young fit patients, BR, very commonly used regimen for somewhat older and patients with some comorbidities, maybe not quite as frail as the chlorambucil obinutuzumab. So we don't know yet how venetoclax plus obinutuzumab compares to FCR or BR, and I think those are important, outstanding questions. Some patients like the idea of being able to just start on a drug and not necessarily need intensive monitoring. It's very easy to start on ibrutinib. You don't have to come back 6 to 8 hours later, 24 hours later for 5 weeks. It takes some time to safely ramp up venetoclax in CLL patients. And I think that's potentially an advantage in terms of the convenience of the drug. So on the other hand, with venetoclax plus obinutuzumab, you have the potential for time-limited therapy. So I think particularly if you're talking to a younger patient and you're talking about 1 year of therapy with the potential for years of benefit versus lifelong therapy with a BTK inhibitor drug, I think there's some real advantages to that approach. Secondly, for patients who have cardiac comorbidities or bleeding issues, ibrutinib can be a problem. And so we worry about patients with atrial fibrillation, but we've even seen some reports of ventricular dysrhythmias in patients on ibrutinib. And so for patients with significant cardiac comorbidities, I think a venetoclax plus obinutuzumab regimen is quite appealing. And I think that patients in general like this idea of the punctuated therapy. Most of the patients I've talked to really prefer that approach, but there's always going to be patients who have different preferences. So I think you really need to kind of present both sides, and I think as the data mature with the ven plus obin regimen, that difference in the follow-up will even out, and we'll have long-term follow-up on both regimens. And
well, it's definitely something we hear from our patients on the myeloid side and CML with the able TKIs and with MDS and AML with the HMAs. At some point along the way, and patients responding, they are going to ask if they can come off therapy. So definitely has to be included now in our discussions also in CLL. Now, in that study that led to the approval of ven with obinutuzumab, there were very few patients with 17p deletion, and it's about, 5-10% at the time of initial therapy will have it, right?
Yep.
But do you use that to help decide on one regimen or other? Do they differentiate?
So far, I would say I don't see any difference. Again, albeit it's very small numbers in the ven plus obin study. We have much more data with ibrutinib in 17p CLL. So there's maybe a little more confidence in the 17p data specifically with ibrutinib. We do see the PFS does not look quite as good for TP53 mutated patients in the venetoclax plus obin study, but that's the case with ibrutinib as well. We just have more data around ibrutinib right now.